Chapter 13 talks about trauma and stress-related disorders. Let's see, we'll first start with post-traumatic stress disorder. So this is the development of characteristics of symptoms following being exposed to a traumatic event. The person may have personally experienced or been involved in the event, or they could have just been a witness to the event that occurred. The symptoms of a person with post-traumatic stress disorder, they will experience fear, horror, flashbacks, feelings of detachment, apprehension, and this impairment has to last longer than 1 month for post-traumatic stress disorder to be diagnosed. So, examples of traumatic events could be like the sexual assault that we just talked about in the previous chapter. It could be being kidnapped. It can be a terrorist attack as well. So the symptoms of post-traumatic stress disorder may be experienced directly, or it may not be. It kind of just depends on the person, so they may experience it directly afterwards, but it also may take them a while to develop any symptoms from episode. But all the symptoms will usually occur within 3 months. So within 3 months after the traumatic event, the patient should be showing signs of post-traumatic stress disorder if they're going to have this disorder. The major developments of post-traumatic stress disorder are re-experiencing the trauma through flashbacks, dreams. The patient will show emotional numbing, such as feeling detached from others. And there'll also be hyperarousal, which just means being suspicious, not trusting people, watching everything, being irritable as well. So that's post-traumatic stress disorder. And then there is acute stress disorder. Acute stress disorder is where they have been exposed or involved into a traumatic event as well as post-traumatic stress disorder. But now the symptoms, they basically need to occur immediately after the event, but the symptoms will resolve in 1 month. So it is not long-lasting like post-traumatic stress disorder. The treatment for acute stress disorder is cognitive behavioral therapy. And remember, this type of therapy focuses on examining the relationships between thoughts, feelings, and behaviors. But if the acute stress disorder is not, the treatment for this is not successful, then it very, very well can progress into post-traumatic stress disorder. Okay, so some treatment options for post-traumatic stress disorder. Most of them are on an outpatient basis, but they can be inpatient if it's a severe enough crisis to which they are at risk for causing harm to themselves or to others. The cognitive behavioral therapy, we've already talked about that. And another option is exposure therapy. This exposure therapy is used for patients who are avoiding dealing with their post-traumatic stress. Okay, the patients, they confront their fears, their emotions, situations, and thoughts about the trauma rather than just attempting to avoid them, not even wanting to think about them. So this forces them to really face what's going on. This helps the patient to be able to control their thoughts and feelings of the event as well. The best treatment for post-traumatic stress disorder is the combination between medication and cognitive behavioral therapy. Medications is based upon the patient's symptoms that they're presenting with, may be given antidepressants, anti-anxiety, sleeping aids, just kind of depends on the patient, what they're experiencing. Disassociation, this is a defense mechanism. It's a subconscious defense mechanism that is used to prevent the they don't recognize that the traumatic event has occurred. They become detached from reality. Which means that they basically will block off part of their life from the conscious during the stressful time. So disassociation, a defense mechanism to basically block out the stress. It allows them to forget or remove themselves from the situation. So dissociative disorder, they use disassociation, that defense mechanism that we just talked about, and they are characterized as dissociative amnesia, dissociative identity disorder, and depersonalization and derealization disorder. So we'll talk about these. So dissociative amnesia is the inability to recall important information of the traumatic event. It can be localized or selective, which basically means a person may be able to recall all of the events, or will be unable to recall all the events, or that they can recall some but not all. All right, this is the real interesting one. Dissociative identity disorder. This is when a person presents with two or more personalities. The original personality is usually unaware of the sub-personalities initially. The original personality can become aware of the sub-personalities through therapy. But each sub-personality has their own way of thinking, their own personality, their own attitude. They can present as a different race, a different sex, a different religion, any of those type of things. So we do not want to touch these patients unless we ask them. This is because patients who have dissociative identity disorder often have been subjected to severe sexual or physical abuse, okay? And we also want to make sure we know which personality we're talking to as well, because some personalities can be violent, while other personalities could be very meek and timid. Depersonalization and derealization disorder, it is characterized by a temporary change in the quality of self-awareness. In depersonalization, it is the disturbance in perception that a person has for themselves. So they may sense that their legs or arms have disappeared, or they have shrunk, or they have enlarged themselves. Basically feeling that you're outside observer of your thoughts, feelings, kind of like you're floating in air above your body. Derealization is the perception of the external environment that has been altered. So distortions in perception of time, such as events that just happened but feel like they've happened a long time ago, or if distortions of distance and size and shapes of objects as well. Assessment for these types of disorders would include looking for the multi-personalities, such as gaps in memories, not remembering buying things or finding things that are out of place and they don't know how they got there. Assess for some sleep disturbance, changes in appetite, alcohol and drug use, and of course we need to assess for suicidal risk as well. Some interventions for a patient with dissociative disorders would include, we need to provide a safe environment. That's always top priority. We always need to assess for self-harm. We need to keep routines simple because this will help decrease their anxiety. We don't want to flood patients with data that has happened in the past. This will only increase their anxiety as well. And again, always use your therapeutic communication and allow the patient to progress at their own pace as the memory is recovered. So don't push them into anything. Interventions for any other, trauma, stress related. So post-traumatic stress disorder, acute stress disorder, or the ones that we just talked about. Remember that safety is important, and we always assess for suicide, just like we talked about. We want to teach patients where a safe place is that they can go if they begin to have any suicidal, destructive thoughts. They need to know who they can call or where they can go to get help at that time. It's important that we refer to the person as a survivor rather than a victim. And also use grounding techniques. And grounding techniques, this is helpful whenever a person is having disassociation or if they're having their flashbacks. This is where they, whenever they are actually experiencing it, the nurse will kind of try to bring them back to reality by telling them who they are, validate what the patient may be feeling, but let them know that they're safe. So maybe say, I know that what you're experiencing right now is frightful, but you are in a safe place. We're just really going to try to increase contact with your reality. So ask them what they're hearing, ask them what they're feeling, both emotionally and physical as well. And that is it for that.